I'm Dr. Aburas. This is the last part of my series on pulp calcification. This one is on the diagnosis and management of symptomatic and asymptomatic pulp calcification of posterior teeth. First, we're going to do the asymptomatic pulp chamber calcification. We can use the 4R operational diagnosis protocol. The first is a patient who has no pain, asymptomatic. They reported that they had an accident, many restorations, recent dental work, and possible orthodontic treatment. Everything else is negative. R2, we're going to focus on the areas of diagnostic interest. I'm going to focus on the radiograph, and you have the 10 ADIs here. Essentially, what we see, a composite restoration in the crown. Focusing on the pulp chamber, we see denticles and some opacities. The canals are opened or patent. Everything else is within normal limits. The second case, or in terms of etiology, is coronal microleakage. Coronal microleakage and oral pathology root resorption induced pulp stones and denticles. Here are the pulp stones. Here are the denticles. And here is the third molar impaction, creating a pressure on the distal coronal and cervical and root portion. This, in addition to the composite microleakage, could create a trigger pulp chamber calcification. Here, there is a history of previous impacted molar which was removed. Again, we see here restorations, composite restorations. This is long-standing temporization. With long-standing temporization, we have coronal microleakage. Here again, you see the opacities. You see the recession of the pulp horn. And if we continue down into the canal, and then we observe at the apical third the loss of the lamina dura and the thickening of the periodontal ligament space. Extremely important landmarks in terms of endodontic pathology and periodontic pathology. This is long-standing temporization-induced denticles. This is periodontal disease-induced denticles. It is absolutely a fact in the literature that advanced periodontal disease create pulpal calcification. Orbach and Mitchell back in the 60s. And as you can see here, the denticles. And of course, you see the periodontal disease. You see the denticles, the clinical crown is intact, canals open, root apex within normal limits, but you can see again the disruption of the lamina dura and thickening of periodontal space, and then the horizontal bone loss. The effect is periodontal disease-induced denticles. Another example of periodontal disease-induced denticles. You'll see it, a recession, and almost like a free pulp stone and other opacities. Then we have tooth wear and crack, line cracks. This is an intact crown. This patient has a habit of chewing on garbanzo beans, created an advanced attrition. And you can see now the induced pulpal calcification, the shrinkage of the pulp chamber compared to the tooth next door. This is what we call either a pulp chamber shrinkage or chamber recession. Again, we follow this up, the crown, the chamber, the canal itself, and then you can see then the lamina dura, and then suddenly we see disruption and beginning of apical changes in the periapical bone. And here you can see the lamina dura, and then we lost it at this level and beginning to have changes at this apical third. The same thing here. And this is the ABC here, alveolar bone crest. This is the patient. This is the actual case. And then we discovered, this is before, and this is after we did some occlusal reduction, we found a central line crack right here. This is a vital pulp therapy induced pulp stone. This patient had caries over here. We did vital pulp management, vital pulp therapy, and this is a new restoration, conservative, no endodontic treatment, and this is the case 5 years later. Free pulp stone. Everything else within normal limits. This is Caries, disease-induced pulp stone. This is the caries. This is the free pulp stone. You see soft tissue radiolucency, the pulp stone. In addition to this caries, down here we have a pocket, a periodontal pocket, also creating some irritation and etiology for the formation of this pathology here. This is not a pathology. This tooth was vital and very responsive and everything within normal limits. This tooth will be treated as vital pulp therapy. Another case of a combination of caries-induced situation in addition to a class 1 amalgam restoration. This is the class 1 amalgam. This is clinical observation. It's not supported by scientific evidence that class 1 amalgam restoration cause cracks. It's an observation, and we have documented this throughout the years. And you'll see here the restoration, the recession of the pulp chamber, the recession of the pulp horn, and then, of course, after that, you see a total pathology in which we have the root apex resorption, endodontic resorption. You see the pathology interradicular and apical and the loss of the ABC. As I mentioned, it's a clinical observation, but it is documented clinically, which is valid. Class 1 amalgam, recession, and then denticles. Class 1 amalgam, denticles. Class 1 amalgam, free pulp stones, and you see here some calculus and periodontal pocket. So this is accumulation, cumulative etiology, the coronal macro leakage, the possibility of a crack, the periodontal disease, all of this together, combination created this pulpal condition, which is calcification of the pulp chamber. This was the asymptomatic case. The symptomatic, again, we're going to use the 4R operational diagnosis, and it is color-coded to guide you in terms of the dental history, the patient's story, the reversible pulpitis, the irreversible pulpitis checks are here, the periapical and periodontal conditions are in red, and the facial and T-temporomandibular joint are in the blue. This is just to guide you where you see the patient clusters. Again, every time we have pain, every time we have a reaction from the patient, there should be some criteria. the site, the onset, the quality, the quantity, the duration, and the subsidence. Again, I'm not going to go in details, but this is basic endodontic diagnosis. You're going to have the chronic irreversible pulpitis. You're going to have the symptomatic irreversible pulpitis. And you're going to have the symptomatic acute apical abscess and apical periodontitis. And you're going to have the reversible pulpitis or dentinal sensitivities. All of these pulpal conditions could exist in addition to the pulpal calcifications, whether it is in the chamber or in the canal. Now we comes to the last part, which is the 4R operational diagnosis, R4. And this is the most important part. The heavyweight in the 4R operational diagnosis is R4. Here, we're going to look for restoration qualities, specifically coronal microleakage. We're going to rule out tooth cracks, and we're going to evaluate erosion and attrition. We will evaluate tooth discoloration and orthodontic problems, occlusion, and tooth alignment. The restoration assessment, again, I recommend highly to go back to the FDI guidelines, in which have a specific criteria for the functional, aesthetic, and biologic. We're going to look for cracks, and you can see remove restorations. Class 1, pulp changes. Class 1, pulp changes with caries over here. We remove a restoration, and we see this is the caries here on the distal. This area is here, and then you see the line crack. And you see the line crack. This, again, was treated with vital pulp therapy. This is the technique, ROTC, which we discuss in other parts of the presentations. Again, the crack line probing, the use of methylene blue, the fiber optic transillumination, and the magnification and photography. The dentin attrition, this is erosion, attrition, and this is erosion. All of this have impact, have effect on the pulp in terms of dentinal tubule closures and pulp calcification. Another example of erosion. And you see the changes in the pulp chamber. At the end of the 4R operational diagnosis protocol, you're going to have 10 reports. These reports will be integrated. Each one will have a weight. We will give about 10% for R1, 30% to R2, another 10% to R3, and 40% for R4. You integrate all of these and you come up with a definitive diagnosis. So how now the management, the clinical management of everything I have explained so far? The first thing which I want to report here, which I do not recommend, that the coronal microleakage, when we remove old amalgams or old composites, we must rule out tooth cracks. We must investigate this area here. Here we could have decalcified dentin. Here we could have cracks. We have a stain and could be cracked. There is a need, definite need for two things: a good periapical radiograph to evaluate the 10 ADI and a pulp test. It is not sufficient to remove old restoration and restore them with a beautiful composite. This is not health therapy. This is not vital pulp therapy. This is aesthetic only with no biological foundation, because we have micro leakage here and we have decalcification. And this is what you see on social media, and this is what you see on the internet in different locations. Another example, if we remove this amalgam, you see there's a crack here. You see the discoloration, micro leakage for years. And to remove it without investigating underneath, you need to rule out tooth cracks. You need to rule out micro leakage. And there are reasons for that. This is, again, this is not my case. These cases I found online. This is what they see, and this is afterwards. This is a beautiful dentistry, but has no biological basis, is not supported by evidence, is not supported by science. And for me, my philosophy that when we remove restorations, I recommend removal of all restorations. I recommend removing all the amalgams, but there are reasons. There are 6 health reasons to replace all amalgams: to stop micro leakage, detect and reduce hidden cracks like this one over here. And that means if we kept the amalgam here and just cut this for an onlay or overlay or a crown, and this cusp becomes loose, you're going to have tremendous micro leakage. We need to disinfect the dentin underneath, promote pulp healing and repair, and reduce the potential for endodontic disease, and replace the amalgam with material which is similar in modulus of elasticity to dentin, which is composite. As I stated, you will have 10 reports, you integrate them, and then you manage the case. So how do we manage? I said manage because sometimes you, as a general practitioner, decide to refer the case. Then if you refer, you should be the team leader. You should instruct the specialist of what is needed, what you have found, and what you want done. Here is the management of asymptomatic pulp calcification within normal limits of 4-hour operational diagnosis. Everything is normal, but you find calcification. You manage it as vital pulp therapy. Avoid pulp exposure, avoid endodontic treatment. That means you need to use strict asepsis, rubber dam application, disinfection with 2.5 sodium hypochlorite, absolutely essential. Perform the atraumatic restorative treatment you desire, composite, veneers, onlay, overlay, and then place the patient on annual recall. In this annual recall, you do a pulp test and clinical examination, means vitality checkup, to be sure the pulp is responsive to cold test only. This is conservative dentistry. We could survive with calcification, specifically cases like this. This is a free pulp stone. What we needed here, we removed these restorations and replaced them with quality restorations. And here we recommend extraction of this impacted tooth. Another case, this is unacceptable dentistry. And you question, how come we have calcification? We have calcification in the pulp chamber specifically because of this dentistry, okay? Because of the micro leakage you have. And you see the layer here, okay? It's been stated that this could be thick halo of adhesive. Absolutely not. We should not have those thick layers of adhesives. This can be avoided. This could be coronal micro leakage, can be decalcification, and it's managed by restoration removal and starting new quality dentistry. If the case now is the asymptomatic, okay, but the patient has pathology, situation like this, we have endodontic pathology, then in this case, you have a choice. If you have the qualification, if you feel competent to perform endodontic treatment on those difficult cases, calcification impede endodontic treatment. Calcification in the canal is diffused and very difficult. May you want to refer this to the endodontist with specific information. In this case, we like to be treated as soon as possible and coronal coverage as soon as possible. Or you may have to perform the endodontic treatment. Thank you for listening.